nearest exit is behind you. There's a green sign, and what we would all need to do is proceed down the stairs to congregate in the front. And I just want to introduce you to, before I introduce the speakers, I would like to just introduce you to a few people of the team. So some of our team I particularly want to point out, right at the back, Naomi Hanaway is a research, oh, thank you, standing up. So Naomi is a research assistant, and so she's particularly important because we've just been given a grant to do some research on Lewy body disease. And Naomi is part of that research grant, so we're really thrilled to actually be able to now be doing the research that we want to do. If you want to take part, some of you already are, if you want to take part in our research program, please find Naomi in the break and give her your details. We would love you to take part. People who have already taken part will hopefully let you know that it's quite sort of enjoyable and interesting and not too exhausting. The other person I want to introduce is Simon Ball, who is at the back. Simon Ball is an animator who is who's got some funding from Alzheimer's Research UK to make a film, an animation on hallucinations. He's already spoken to a few people who are here, and he's looking to speak to some more people who might be interested in describing either their own or their partner's hallucinations to develop this into a film to really to educate and show what hallucinations are like. I also want to introduce, Esther has just got up. Oh. Esther, many of you will already know Esther, who's part of our carer support group now. I've really been coming quite a few times. And Esther's interested in setting up a buddy system. Is that right?
Yes, I mean, the thing is that I got a whole lot of people's email addresses last time I was here, and I think on the first occasion, and I haven't done anything with it. And this was largely because my caring role became so intense, I really couldn't do anything other than that. And, well, yes, it's sad that he's died, but he died in October. But in a lot of ways, it was good for him and for all of us that he died unfortunately. So if there are people who are interested in having buddies, I'm willing now and have more time to do that.
Brilliant, thank you. I also want to introduce you to Claire and Olivia. Where are they? Oh, they're downstairs bringing people. Okay, brilliant. They've organised it, so I'll introduce you after. And I just want to make a note. Sorry, I'm eating slightly into your time. That I've had some conversations with Parkinson's UK about opening up carer support through their infrastructure. I'll talk a little bit more about it in the afternoon session. The reason for mentioning it now is that they are, and I am, looking for people who might be interested in helping to inform them about what sorts of things could be helpful. So come and talk to me in the break if you think that's something that you could help with. And the next person I want to introduce is Eva. Eva, brilliant. And I think you were going to come and say a couple of things. Lovely. Thank you.
Hello, my name's Eva Tate, and I'm the Major Appeals Manager for Rare Dementia Support, and I also look after the Rare Dementia Support Fund with my colleagues. I just wanted to tell you a little bit about the charity that supports these support group meetings. Rare Dementia Support is a fund that's held by the National Brain Appeal, which raises funds for the National Hospital for Neurology and Neurosurgery in Queen's Square. Over the past 3 years, we have raised up to 150,000 each year, and we're increasing this target to 250 this year and up to 350 in the next 2 years, with the ultimate aim that we'll be able to, hopefully, in the next 5 years, build a centre for rarer dementias. We also hold the Dementia Research Fund as well. So the National Brain Appeal is basically the charity, and then we have 2 funds on top of that. We have a dinner coming up, a gala dinner coming up at the end of February called Mission Possible, and it'll be held at the Cavalry and Guards Club on Piccadilly. And if anybody works for any companies or knows of any companies that they think might be interested in possibly advertising or sponsoring within our programme, please feel free to email me or my colleagues. I'd also like to introduce you to our Senior Fundraising Officer, Alexis Gebby, who's going to be here at lunchtime. So if anyone has any questions or wants to buy any Christmas cards or just wants to have a chat about how we're funded, please do feel free to speak to Alexis or email myself as well. Thank you. Nice to meet everybody.
So I'll just say a couple of very quick words. So I look after everybody who wants to do challenge events and fundraising out in their community. So if you know of any sort of keen runners or cyclists or swimmers or anything like that, or if you want to take part in an event, like I said, we're going to be over there at lunchtime. Just come and have a chat to me. We've actually got, I think you probably know Nikki Zimmerman. She's running the London Marathon for us next year. There's also a team of rare dementia staff actually taking part in the London Marathon next year. So it's very exciting. Come and say hello, and we can have a chat about fundraising.
So one more thing before I introduce our speakers. If anybody feels that the topics that we discuss are too much, or they're not interested, or they just don't want to be just want to take a few minutes, there is a room at the back that is called the breakout room. So there is some space if you want to just take some time to yourself. And there'll be Louise Leyland, who's got her hand up here, who's our postdoctoral researcher, will be there keeping you company if you'd like that. So, any questions, or should we move on? Excellent. So I'm delighted to introduce Dr. Jalesh Panicker, who is a consultant Uro-Neurologist at Queen Square, and and Collette Haslam, who is a nurse specialist in Uro-Neurology. Many of you have mentioned that urinary symptoms and also some sexual symptoms are really have an impact on life. So I'm delighted to have the absolute experts.
Thank you, Ramona, for those words of introduction. So my name is Jalesh Panicker, Collette Haslam. We work together as a team at the National Hospital for Neurology at Queen Square. So as Ramona mentioned, I am a neurologist, and once we have the slides up, we'll get going. But essentially, this talk is sort of everything below the belt, sort of urinary and sexual problems. Thank you. That we come across in individuals with neurological disease, but in particular individuals who have sort of dementias, and specifically dementia with Lewy body. And so in the program, it sort of appears as sort of a back-to-back presentation, but rather what we've done is sort of a double act. So it'll be one presentation, and you'll be seeing both of us up together during parts of the presentation. And so the questions really, I hope that this presentation would answer would be sort of what are the different types of urinary problems that individuals with DLB can report, and why it occurs, and also, more importantly, is what can be done for someone who reports problems with their bladder or sexual problems as well. So this slide is probably not meant to be read, but it's just listing out all the different symptoms that an individual with a neurological disease can present. So there's a long list you can see here, and amongst this is the bladder. And you would probably relate to this very well, because there can be other symptoms that preoccupy an individual who has a neurological disease. But in some conditions, such as in this case multiple sclerosis, a large percentage of individuals do report problems with their bladder. And they also report problems, sexual problems as well. Now, there could be many assumptions when these symptoms began, that it could be maybe just part of getting older. It might be because of the prostate. It might be because of having had children. But indeed, in neurological diseases itself, these themselves can cause problems with the bladder and problems with sexual functions. And so recognizing that, and then understanding to what extent this is because of the neurological disease, and to what extent this could be because of some other urological problem or a gynecological problem is sort of the work what we do. And of course, the treatments for these urinary and sexual problems depends upon what we find as a cause. Now, there's actually not much written about the bladder problems in individuals with DLB, but there is one study that actually sort of compared between individuals with different neurological disorders, DLB, Parkinson's disease, and Alzheimer's disease, 3 conditions that all of you would be familiar with. And I won't bore you with the details, but essentially what I wanted to highlight was that in these studies, it seems to suggest that individuals with dementia with Lewy body have a much, much greater percentage of reports of symptoms of their bladder compared to, say, Alzheimer's disease and, in fact, Parkinson's disease, which is actually rather surprising from our end, because if we look at the referrals that come to our department, we see predominantly sort of Parkinson's disease and some individuals with Alzheimer's, but we get very few individuals with DLB. And we're not exactly sure the reason, but we think it's more to do with sort of making it aware, people aware that there can be problems with the bladder. And I think societies like Parkinson's UK have quite a bit of information out there about the bladder. There's information leaflets that are there. So there's readily available, you have a read, and you recognize your symptoms and think, oh, I've got that. And then, of course, you speak to your Parkinson's specialist, and then you get referred on to a place like Uro-Neurology. Whereas, I suppose with dementia with Lewy body, I suppose it's one amongst many symptoms, and it might be that there are concerns. Well, there are the symptoms. Well, it might not be related to dementia, but also there is this sort of concern. Or there's an assumption that this is part of the dementia process. Nothing can be done, and also that if we give medications, that it can make the memory worse. So there's lots of assumptions about the bladder and dementia. But this is something that we've been interested in the last few years. And in fact, the number of individuals with problems with memory who come to our clinics have actually steadily increased. And so now we have our own little sort of a pathway that we follow for individuals who have cognitive impairment, in whom we think they shouldn't be followed down the ordinary algorithm for bladder problems, but they need a very rather bespoke approach, which we have now to offer. So this is a picture of a urinary bladder. And essentially, when you have problems with the bladder, it's useful to think of them in terms of 2 sets of symptoms. So you can have problems of your ability to store the urine. So all of us in this room right now are storing their urine. But as you are sitting and listening to this talk, if you have problems with the bladder and you're trying to store that urine in the bladder, you do start to experience these sort of symptoms. So one is urgency, which is this compelling desire that you need to go out and pee. And it could come in seconds, it can come in minutes, and then there's a warning time that's there, and each individual will know their warning time. Some of us might say that, oh, I have an urge to pee, but actually I can hold off till lunchtime. Whereas others might say, I've got this urge to pee, I know I better get up now. And that sort of warning time differs between individuals. And urgency is itself is a perplexing symptom, because you have some individuals who are perfectly fine and then they catch sight of the front door. It's what we call latchkey urgency. And as they're fumbling for the key, try to get in the keyhole, they become urgent, and sometimes they wet themselves. And this is urgency incontinence. Some individuals, this is actually their main concern. Other people, it could be catching sight of the toilet door, for example. They're fine, but then they have this urge, so I might as well get up from the couch and go to the toilet, but then you catch sight of the front door, and then you become urgent, and then sometimes it culminates in an episode of incontinence. Other times it's that symptoms of urgency, and then you reach the toilet, you begin to unzip, undress yourself, and at that time it becomes such a compelling desire, and then it culminates in leakage. So urgency is very much a symptom of what I would say sort of mind over bladder, because it is very much a neurological, it is very much a symptom of a neurological process, but there is a degree of control which are influenced by sort of voluntary influences. And so this is where Collette will tell you about bladder retraining and bladder scheduling, where actually you can actually try to get a handle on urgency. And then there's sort of frequency, which is sort of the number of times an individual goes to the toilet. And there isn't a set number, but if we find that someone is going more often to the toilet, it can be due to different reasons. It can be from having what we call an overactive bladder, which means the bladder is sort of misbehaving and has a life of its own, which is what we come across in individuals with a dementing illness. But it could be from drinking too much, for example, if you've had a very high fluid intake. It could be the type of drink, and Collette will tell you about the different beverages that are known to irritate the bladder and make the frequency worse. And if it extends into the night, it's what we call nocturia, which is getting up at night to pee. Now, nocturia is a tricky symptom because I think just by listening to that symptom alone, it doesn't tell us a whole lot. And so as clinicians, we then have to sort of probe a bit more. Because sometimes it can be from a misbehaving bladder, which is making you get up and go. Now, a lot of it is related to sleep. So if you go into a deep stage of sleep, for example, you might not recognize the symptom of urge, and you might actually sleep through. And this is why we find that in some people, when they take hypnotics or they take melatonin, for example, they can actually sleep through, and their nighttime frequency comes down. Lighter sleepers probably will perceive that urge, and then they wake up, and then they go. And then, of course, you have what's called convenience pee, so that you get up because of some other reason, maybe because of a spasm or a bad dream. And then you're lying in bed thinking, well, I might have to go to the toilet sometime later on, so I might as well go for a pee. So it's not really an urgency there. There's no urge to pee, but it's sort of just in case. And we call this convenience voids because we don't want to be treating that with tablets for the bladder. We want to sort of understand why the person has actually gotten up and gone to pee. Now, what's slightly more complicated is it might not just be an overactive bladder, but it might be a volume issue. And some individuals produce a considerable amount of urine at night. So most of us in this room should be producing 1/3 of our entire urine output at night and 2/3 in the day, right? But what happens in some of the conditions, particularly in Parkinson's disease, what we've noticed is that this sort of flips and it becomes the other way around. And so the person might be going to the toilet maybe 2 or 3 times in the day, but then they go to bed and then it starts every hour they get up. And some individuals will actually recognize that I'm producing much more urine at night than the day. And this actually isn't a urological problem, it's a medical problem. It can be because of sleep disorders, it can be because of the pills you take, it could be because of the ankle swellings in your feet. So it's actually probing a medical cause for that nighttime frequency. And if we recognize that, and if we sort of address that, quite often we find that the nighttime frequency improves. And then if the urgency becomes too much, then you become wet. So incontinence is actually the end product of something else. So it can be that you're desperate to go to the toilet and you don't make it to the toilet on time, which is called urgency incontinence. Sometimes incontinence can occur when you cough and sneeze, so effort and exertion, so it's something we call stress incontinence. Or you can have incontinence when you just continuously dribble. And it might be because you're holding a large amount of urine in your bladder, which we call an overflow incontinence. So when you tell your clinician about incontinence, what we do is we ask a few more questions to just qualify that, because then our investigations differ, but also the treatments differ. So how you would treat someone with stress incontinence from a weak pelvic floor is different from someone who has urgency and incontinence. Now, these are symptoms that all of us in this room will recognize. When you're urgent, when you frequently need to go, or as a clinician, it's a symptom that you can easily relate to and ask an individual, do you have urgency, do you have frequency? But what's not so easy are the symptoms that we call avoiding symptoms. And these are symptoms that occur when you're actually at the toilet and trying to pee. So you might hesitate a bit, and the urine just doesn't come for a while, and you just wait, and it comes after a bit. And then sometimes you have to sort of bear down a bit, or strain to get your stream to come out. Or once the urine flow does start coming out, it's sort of interrupted, so it stops and starts and stops and starts again. Or it can be what we call double void, where you pee, and then the flow is finished. You think everything is over, and then a second pee happens again. So it's a substantial volume, what we call double voiding. Now these symptoms suggest that there's something wrong with the emptying mechanism. Now, if someone has gone into acute retention where suddenly they can't pee, then it's recognizable. But in most individuals, the voiding problems are actually quite gradual. It's not something you're going to recognize. And if it's a man who goes to a public urinal where they might sort of subconsciously compare how they pee compared to the next person, and they realize that there's a problem, you might not actually recognize it if you pee in your own private toilet. So these are quite gradual symptoms, and hence they're not, from a clinician point of view, they're not reliable. So if we were to ask these symptoms, and if someone said that, no, I don't have any of these symptoms, we wouldn't sort of settle with that. We would ask the patient to carry on with a test called a bladder scan, just to see what's left behind after the person has peed. Because many times we find that there might not be these symptoms, but the person who has just peed has left behind a considerable amount of their bladder, which should have been emptied. And so we do ask about the voiding symptoms, but I would say, and I think Collette, you would agree as well, they're probably not as reliable as the storage symptoms. Now, between dementia and lower urinary tract symptoms, it's a two-way relationship between this. Because we know that in someone who has problems with memory or any of the dementing conditions, that itself can cause lower urinary tract symptoms, which are the symptoms of urgency, frequency, and incontinence. For example, if they have a bladder condition as a result of the neurological disease, that could be one cause. We know that when the brain is affected by a cognitive condition and the individual perceives symptoms from their different organs in a different way, and hence so the symptom of urgency that I've described might not get the same priority as, say, another symptom when the process in place to perceive urgency is affected. But also, what happens when you perceive urgency? So one individual might immediately go to the toilet, perceiving urgency, thinking, I might as well go now because I can foresee that there might be a problem if I hold off. Whereas an individual who has a problem that affects their cognition might not really be able to sort of factor that in. So what if doesn't come into the picture. And so because of the cognitive and behavioral changes, the way one perceives urgency becomes different, and therefore it might culminate in incontinence. There's a term that we use called functional incontinence, which is something I want to introduce, which means that you have a bit of urge or urgency, but then there are other reasons why you can't make it to the toilet on time. One could be, to say, if you have Parkinson's disease, the time it takes to get up from the couch, make your way to the toilet, unzip yourself, and pee is considerably longer compared to someone who doesn't have Parkinson's disease. So it isn't primarily a bladder issue there where the person becomes incontinent, but it's because of problems with mobility or dexterity. And if we can recognize that from the symptoms, from the history we take, we then think about, well, what are ways in which we can speed up the process? Do we need to think about a portable commode, for example, or something on those lines? The other situation where we find this is a common situation in homes in Britain, in which the individual resides on the ground floor most of the daytime, and the sole toilet in the house is on the first floor. So what happens is that individual experiences a symptom of urgency, needs to do something about it. By the time they make it up the flight of steps to the toilet and then they do everything else, they become incontinent. And if we find that out from the history, then once again, it isn't starting a tablet for that or starting a pill for that, but actually thinking about how can we make it more practically feasible for the individual to actually pass urine at the ground floor itself so they don't need to make that trip to the first floor. Now, we know there are numerous other medical and surgical conditions that an individual with dementia can have. I've talked about enlarged prostate, for example. I've talked about a woman who's attained the menopause and now has a weak pelvic floor. But there can be other medical conditions such as diabetes, such as heart failure, and these conditions are predisposed to problems with the bladder. And there can be tablets. So even the medications themselves can cause bladder problems. A classical example is a water tablet, what we call a diuretic, which is commonly prescribed for individuals with high blood pressure. And we know that a water tablet can make you pee more often. That's the purpose, is that they want to prune you out. But what happens is it makes your urgency and frequency more pronounced. And so when we talk to an individual who comes to us with bladder problems, we go through this long checklist of conditions that might interfere with their bladder symptoms and, more importantly, are reversible and addressable. Now, it's also, we know that the bladder symptoms themselves can make the cognitive problems worse. We know that a person who's had a bad night's sleep because of nocturia will actually then be unrefreshed when they wake up in the morning and therefore will have a terrible day. We know that if an individual has recurrent urinary tract infections, that's going to affect their quality of life, but it'll also predispose to sort of delirium and other sort of problems. And we know that if someone has a wet pad, we know that itself can cause delirium. And so it's important to recognize these factors that could potentially make the cognitive side of things worse and that are reversible. And I talked about the medications, because some medications that are used for the bladder can make the memory worse. And this is something that more and more we're beginning to recognize, but it's quite important that before a medication is started for the bladder, that we risk assess the individual and see what is their risk for developing cognitive problems. And for someone who has dementia, it's important that we don't prescribe all of these medications. There's some of these that can be given, but we have to be very careful and we have to monitor the individual very well when we start the medications. Now, if someone has a relatively stable bladder, right, they have a bit of urge, some frequency, not some nocturia, but managing fairly well, but there's a recent worsening. Now, we know that many of the dementing illnesses are gradual processes, so there's nothing that happens overnight. But if we find that over a span of days or weeks there's a rapid deterioration in the bladder control, there are some questions that Collette and I will think about. One is, could it be a urinary infection? So we talk about urinary infections, and of course the symptoms that come to us are the classical symptoms of a burning urine, tummy pain, feeling under the weather, fever. These are the classical symptoms of cystitis or urinary infections. However, when someone has a neurological disease, they might not actually perceive these symptoms. And so the symptoms of a urinary tract infection might be actually quite ubiquitous, and also they would actually blend with the rest of the neurological disease. And so sometimes it's difficult to recognize that there's actually a urinary tract infection going on. The individual might just report a change in their bladder frequency, a little bit of discomfort, and so sort of more subtle signs and symptoms. And so we have a very low threshold in someone who has a neurological disease like dementia to actually test for a urinary tract infection, because if we find that, and if we treat the urinary tract infection, not only is their bladder symptoms going to get better, but it might be a reversible cause for deterioration in their memory. Medication, so the cholinesterase inhibitors that many of you are familiar with, like rivastigmine, donepezil, they do make the bladder worse. And in fact, there are studies which have shown that 1 in 10 of individuals who have participated in research studies that actually their bladder does get worse. And this is something that we sort of caution to anyone who's starting on these medications or who has recently been started and they come to us is, tell us about your bladder. Has there been a change after starting the medication? A medication that you might be familiar with are opiates, such as tramadol and morphine, that sometimes are given for pain relief. For example, if someone has fallen over and broken their hip, for example, then they might be given medications, and these can cause problems with the bladder. If there's been a recent restriction of mobility, a fall, or if someone has Parkinson's and their mobility has become worse, then their bladder symptoms may become worse as well. And also if the individual's constipation, which is probably the most important cause. So if someone comes back to us and says, well, my urinary leakage is worse, the first question we will ask about is, how is your bowels? And time and again, we'll find that there would have been a recent deterioration in their bowels, either bowel incontinence or constipation. And many times we find that by just managing those symptoms, we find the bladder symptoms improve afterwards. So you have bladder problems. Ramona, or one of your clinicians, then refers you to Uro-Neurology, or Ramona might actually do her assessments in clinic. And so we'll ask you these symptoms, sort of about the things that I've talked about already. We will invariably ask for a urine sample to test the urine. And so what we do is we put what's called a dipstick into the urine. It's a sensitive but not a specific test for urinary tract infection. So if the dipstick, which we can do in clinic, is negative, then we're fairly certain that there is no infection. However, if it comes back as positive, it's not 100%, and it's important then to send off the urine to the lab. And then we also will ask, we'll also check your bladder to see after you pee whether there's urine, significant amount of urine left behind in the bladder, and we will also give you a diary to take home. And the diary is quite useful, and Collette will tell you a little bit more about that. But in essence, what we'll be asking you to do is maintain a log of at what time you pass urine and what volumes you pass. So you've been using a measuring jar for that. And then with another measuring jar, we'll ask you to then note at what times you drink and what volumes you drink as well. We do sometimes offer more invasive tests like urodynamics, but I must say that in individuals with dementia, we try to avoid all invasive tests, and we make it as non-invasive as possible. And of course, we talk about treatments. So this is sort of a portable bladder scanner, so you don't need to go to a radiology department. It's a handheld ultrasound. So that's a probe that goes over the tummy, just below the belly button. And so the person has passed urine, and then we measure how much is left behind. And it should be, we use an arbitrary figure of 100 ml. If it's more than that, we think that something's not right. So I think I will, and these are some of the medications that are used for the bladder, which we can discuss during the question and answer session. So these are the medications I would say that we would like to avoid, the anticholinergics, antimuscarinic. There's two amongst this, however, that we do offer. One is called trospium chloride, that some of you might be familiar with, and the other is called darafenacin. So these are the two that we would consider in someone who has problems with their memory. There's a new kit on the block called mirabegron, which works entirely different from this, and this is safe to use in individuals with memory problems. So we do have a few medications that are available for individuals who report problems in overactive bladder. Now, Collette will take us through sort of practical management.
So just what? Yeah. Right, I'm just going to talk about some practical things now to try enhance the bladder. Okay, I'm just going to, which one is it? That one. Okay, so we talked about, Dr. Panicker, Jalesh talked about the fluid intake. So it's really important that we kind of look at how much we're drinking, because it's quite, it is a habit that people stop drinking when they've got a bladder problem. So that actually causes more bladder problems in the long term. One about urinary tract infections, and also concentrates your urine. So that acts as a bladder irritant as well. Now, we aim for 1.5 litres to 2 litres. That's actually quite difficult, and a lot of us do find that's quite difficult to drink during the day. But it's pacing yourself during the day, and remembering that jellies and custards and ice creams are all fluids, and soups are all classed within this 1.5 to 2 litres. So it's not all about drinking 2 litres of water a day. So caffeine, we talk about reducing the caffeine intake, and certainly a lot of us quite like our coffee to get going in the morning. And I wouldn't say you need to cut it out completely, because sometimes it's good for the bowel as well. It kind of gets the bowel moving in the morning. So perhaps just cutting it down, make sure you only maybe have 1 cup of coffee a day, and looking at the type of coffee that you're actually drinking, because obviously some are stronger than others. Some teas have got more caffeine than others as well. And remembering things like green tea, which are healthy, actually do have caffeine in them. So it's looking actually at the packet when you're actually picking your fluids. Okay, so again, looking at alcohol, citrus fruits, juices, cola, things like that, and be careful what the type of fluids that you're actually drinking. Okay, so we talked about bladder, we looked at the diaries, and we're talking about bladder retraining. Now, that's because it becomes a habit an awful lot of the time going to the toilet, and a lot of people that, if they've actually had some incontinence episodes, they'll actually go what we call just in case. So every time they see a toilet, they'll go to the toilet, whether they need to go or not. And it's trying to get people out of that habit of going sort of thing, and trying to think, why am I actually going to the toilet? Is it my bladder that's telling me? Or is it just because, just in case? So we sometimes have to look at a diary, and that's why a diary is really important, to see how often you're going to the toilet, and to see whether it's actually the need to go to the toilet. And sometimes that's a kind of re-education of your actual bladder. And it enables the bladder to hold on to more urine, because if you're going by the clock, every hour, every half hour, your bladder actually gets used to that amount. So it doesn't learn to kind of stretch. Okay, and we'll look at bladder scheduling.
When are you going to the toilet? Do you go in the morning? Do you go before you have something to eat? So it's getting into habits like that as well perhaps will enable the bladder so that you're not waiting to the last moment as well. So you're kind of looking at, well, we'll go to the toilet before breakfast, we'll go to the toilet when we get washed, we go to the toilet perhaps at lunchtime. So you're actually pacing yourself also. Okay, so general measures. Now, obviously with people with dementia, it's kind of difficult sometimes to remember where the toilet is. So a lot of people will have access to getting posters for their, or plaques for the toilet or on the area towards the toilet. And we find this quite useful in hospitals sometimes. So certainly we have a picture of a toilet so people know which door. I noticed actually here when I went to the toilet earlier on, absolutely, it was like a blank of white. I couldn't even find the toilet door. So, I mean, I was kind of thinking, this is a bit much when we're the type of day that we're actually having. So I think, so I'm sure there's a lot of people having problems today. So I think, so they could do it with a lot of these signs. So I think it's something that we need to consider in our own homes. Okay, actually going to the toilet and actually sitting on the toilet. A lot of people have problems sitting down and getting back up off the toilet. So I really think that arms beside the toilet are a useful thing. I will bring in personal. My mother had dementia, and certainly these were things that we found really useful in the house. And it probably was useful that I had a continence background because I could actually kind of ask for certain things. But we found it very useful for my mum to feel comfortable sitting on the toilet, that she could get up and down without a fear of falling. We also had a raised seat in the house. And we found, and I have read up about this, and it certainly says that if you use a blue seat rather than a red seat or white seat, patients are more, people are more able to actually notice where the toilet actually is. So when they're sitting down, they see where they're sitting and they feel that they're not hovering over something and feeling that they're going to fall. Okay, obviously commodes beside the bed. And I think if you look at something that looks a wee bit more aesthetically pleasing, as like a chair that actually looks like a proper chair, people will find that more acceptable having it in their bedroom or having it in the living room, that it's got quick access to the toilet. Okay, certainly adjusting clothing. We talked earlier on about how perhaps getting your zip down or opening or pulling up your skirt might be a wee bit more difficult to actually access. Certainly Velcro and using studs and things like that are much easier for quick access to the toilet if you've got urgency. So that's the type of thing there. These can actually be bought online, or actually a lot of, if you're very good with your hands, you can actually adjust them yourself. Okay. Something else that's actually available is a treatment called percutaneous tibial nerve stimulation, PTNS, and transcutaneous tibial nerve stimulation. This is a treatment that you perhaps will use if you can't have medication, or you want to use it along with medication, and it's used for frequency and urgency. So this is non-medicinal treatments. So it's usually a 12 course of treatments that's available for half an hour, and you can either use it in the house, or the TTNS is available in the house. PTNS is usually available in the hospital. And certainly we're kind of looking at TTNS, the transcutaneous one, which is the patches for people to use at home now. And perhaps you can use it as you would like. And certainly that's something that a lot of people were using rather than, as I say, medications. So it's something to be considered. So we're looking at, we talked about urgency and frequency, and the first thing you must do is test for a urinary tract infection and measure the residual volume, because it really depends on that how we move forward and our actually management options. Certainly if there's a high residual volume, and we tend to look at over 100 mils, 150 mils, we might have to look at how we're actually emptying the bladder, because a lot of people don't empty the bladder for all sorts of reasons. So you perhaps might have heard of clean intermittent self-catheterization, and that's when people pass a tube into the bladder via the passageway up into the bladder, and they empty the bladder out with a tube. Okay, and there's different types of tubes, and this is something that men and women are taught how to do. And sometimes if the person with dementia cannot do it themselves, we sometimes teach their partners or their carers how to do it as well for them. This might be something they do before they go to bed to make sure that their bladder's completely empty before they get to bed. Okay, there's also different types of catheters. So usually we can find a catheter that will suit your lifestyle and how you manage at home. Okay, so again, it's not suitable for everybody, so we do need to assess people, and you need to be taught properly how to do it. So you need to find a nurse that actually knows how to teach people with dementia how to actually do the intermittent catheterization, because it does take time, and sometimes you have to see somebody, quite a few times before they'll actually take it on board. And certainly follow up. As things are perhaps progressing, we might have to look at the different catheters that we use, or how the actual regime for doing the catheterization. So Jalesh will just talk about this type of catheterization.
So you heard about intermittent catheterization. So this is a situation where the catheter isn't there permanently. You introduce the catheter, empty the bladder, it comes out. Now, an indwelling catheter is when the catheter remains within you. So the catheter can go in through the opening through which the urine comes out, that we call the urethra, and so it's called a urethral catheter. Or it could be something through the belly that we call a suprapubic catheter. So this is a picture here of your lower tummy. That's the bladder. And the catheter goes into the bladder, and it drains the bladder. And there are some situations where a permanent catheter is required. So if someone has problems with urgency and incontinence, they've tried all the treatments that you've heard, and still there's problems with urgency and incontinence, sometimes an indwelling catheter would be the way forward. Now, what we haven't talked about is what happens if you can't pee. And there, unfortunately, are not many treatments that are available to get someone to pass their urine. So you've heard about intermittent self-catheterization, but if intermittent catheterization is not feasible for whatever reason, then that might be another reason why you'd have a catheter permanently there. Now, between the two, that's a urethral, and the one through the tummy called the suprapubic, we always prefer in the longer term to have a suprapubic catheter. It does entail having to go to a urology unit and maybe stay there overnight to have the catheter fitted. The first catheter change, the individual needs to come back to that clinic, but subsequent changes of the catheter can be done in the community. And it's just for many reasons that we prefer a suprapubic catheter over a urethral catheter. And we also know that with increasing disability and with problems with memory, it might actually be easier to manage a bladder with an indwelling catheter compared to a urethral catheter.
So if you do have an indwelling catheter, chances are you'll have a catheter bag. What I would say to you is that if you have a leg bag on, a lot of people don't like the feeling of the leg bag next to their leg because they feel the warmth of the urine. So they actually feel as if it's uncomfortable from that point of view. And also it can act as an irritant, and it's make people are more aware of actually having this thing round their leg, if you like, sort of thing. So some people can use, on the right-hand side, there's the catheter valves. Now, they're not suitable for everybody, and really, you can't use it without supervision, if you like. There's also different types of valves that perhaps for hand function you've got to look at as well to see which ones. So it's not a case of one valve suits all. So it's something to take into consideration when you're looking at that. Obviously, people will use sheaths and pads, and certainly they're only as good as they're put on. If they're not put on properly, they're going to leak, and it's lots of different types. Again, if you haven't got on with them in the past, it's maybe because the fitting's not being correct. So it's really important that you perhaps persevere with that, but it can act as an irritant, and they're not suitable for everybody. Again, what you get from sometimes the district nurses is not what you can buy over the counter, but it does depend where you live, what you actually get supplied, unfortunately. Okay, so we're looking at factor selecting it. Obviously, it's one appliance does not suit all, and sometimes we do have to look at finances and what's available in your area. Okay. It is a multidisciplinary approach, and certainly sometimes we do have to involve occupational health and your occupational therapist, and certainly the physiotherapist to perhaps work with you to find something that's suitable for your house, looking at the rails and things like that. Okay, so we're just going to kind of recap. Urinary problems are common. So I'm taking Dr. Panicker's slide here, but I'm aware of the time. And also to check if the bladder's empty. And that's the most important thing that you have to actually get done, is to make sure that somebody is scanning your bladder to see how well you're emptying, because that will make the difference to any treatment options that we think perhaps working with you moving forward. And certainly look at the fluid intake. Pelvic floor exercises are suitable for some people, but not everybody, because we've got to remember how to do them, and even people that don't have dementia don't remember how to do them, and do them. And certainly we look at medication, and perhaps the way forward might be PTNS or TTNS for the individual. Right. We're kind of, we'll have to watch our time, so perhaps we'll just kind of quickly go through.
I hope, are you happy that this extends 5 minutes more? Or shall we just do question and answers?
Yes, of course. So should we take a couple of questions? We've had a lot of information about, thank you, a brilliant talk. So really covering everything from,
That's
oh yeah, right. So covering everything from the beginning to quite a lot of details. Do people have some questions about urinary symptoms? And then we'll spend a few minutes thinking a bit about sexual function.
The ways of
So why we talk about sex and sexual habits and things like that is because it's a natural part of living. Okay, it's part of our lives as we grow older, and even as children, as we get older, it is important that we actually address the sexual aspect. And I think, especially from a healthcare professional, I think a lot of people will say to us, actually, healthcare professionals do not even acknowledge sometimes that actually people have a sex life outside their condition, sort of thing. So it's something that we are trying to address by giving these talks, and by giving talks to more actually healthcare professionals about actually we need to talk about it. Thank you very much. Okay, so sexuality, key aspect of personality and behaviour. So we have to look at perhaps how we are just now and how our sexuality has changed over our condition. It is a basic need, human need, and most basic, we need comfort and we need intimacy, and it's part of how we express ourselves, as part of being an individual and as part of being a couple as well. Okay, so for many, kind of reading up more about the dementia side of things, and a lot of people feel that's what's missing from their relationships, sort of thing, and also, but it can continue, with a bit of thought, perhaps to be continue to be a pleasure to have this intimacy with our partner, and it's something that we need to consider when we're moving on. Okay, so it's opening up, we need to ask about it, and sometimes it's quite difficult, and people get embarrassed. We all say it's a British thing, people asking actually about their sex lives, or asking, how we move forward, or who do we actually ask for help. But sometimes it's actually, if we are not talking about it, who is talking about it? So certainly, oh sorry, it's not a very good slide. Darkened it down too much. So certainly a lot of people, when we kind of looked at it, and we kind of looked at it was more perhaps patients with people with MS that are kind of asking about it, sort of thing, and they were saying, well, really, if the healthcare professionals aren't asking about it, how can I bring it up in an actual consultation, sort of thing, So a lot of, perhaps if it's a physical thing or it's a kind of functional thing, people will bring it up, but when it's actually emotions and what's going on and how we're actually dealing with it, people won't bring it up. So, that's something that we're very much aware of, that actually we need to ask about it now. How is, from a sexual function point of view, is there any actual issues, or is there any issues as a couple, that type of thing, and moving on from that point of view. So again, if we're looking at how we move forward, sometimes there's less interest in sexual activity, or there's more interest. Sometimes it can go the other way, that somebody actually has become, wants to be more sexually active, and sometimes that is because it's they forget that actually they've had sex, sort of thing. And sometimes that can happen. They can forget actually we've just had sexual intercourse or something like that, and then 5 minutes later people are wanting to have sexual intercourse again, and that's something that we need to address as well. So I think, again, the actual performance isn't the same, or sometimes as conditions progress, that might change. Against the sexual behaviour, certainly some partners will say, well, actually, sometimes it's as if, I'm not there in the room when we're actually having sexual intercourse, and perhaps, as I say later on, there's no cuddling, there's no intimacy, and they feel that that can be quite different. And again, for the person with dementia, sometimes they feel that because perhaps they're not, their partner's become a carer, if you like, that's changed as well, and they're not as intimate as they used to be. And again, the change of inhibitions. Certainly when people, if you read round it, certainly when people are out, perhaps because they don't recognise people, they might address, people with dementia might address somebody as their wife or as their partner, and that can be quite embarrassing all round. So certainly we have, from this point of view, inappropriate sexual behaviour in dementia, and this is something that we are perhaps aware of, and sometimes it's been reported a little bit more, and certainly perhaps that is something that Dr. Panicker is seeing a little bit more of, and it's certainly something that, and we tend to see it quite a lot when we, in inpatients in hospital community, and we sometimes get referrals from that, and we tend to see it more within the male population, certainly, or it's not reported as much with the female population. Okay, so there's other, so the needing to go to the toilet, again, if we talked about perhaps picking at the clothing, and sometimes it's as if people are touching themselves, but actually they're not touching themselves, it's because they're actually touching at their clothes to get, because they want to go to the toilet, or they feel their clothes uncomfortable. Again, it can look as if they're touching, people are touching themselves. We talked about boredom or agitation, that's something to do that might appear sexual. If somebody expresses the need to be touched, sometimes it's because they feel they're losing that sensation of intimacy with each other. And it is a basic need to be touched and to be caressed and hold. Sometimes, when, especially you notice it sometimes in couples, and a lot of people are saying that when one becomes a carer and one becomes a patient, perhaps you lose because you're doing perhaps cleaning up, you're kind of taking people to the toilet, you're doing other intimate things for them. You don't even perhaps hold hands or caress or kiss goodnight. All these sorts of things are really important as well. Okay, so normal practices, obviously, it says obviously Masters and Johnson's going back years ago, and we looked at it, it's a natural response, and certainly that's something, and sometimes the impossible is, and sometimes we've got to change our perception of what we want, because things are changing, and perhaps we need to kind of move with how things are changing and adapt ourselves. Okay, so as I said, again, I'm aware of the time, but certainly comfort, devotion, love, it's a physical need, and that's why we need to kind of look at it as a whole. Okay, so we'll talk about.
I'll just be very brief and just say that there are different treatment options that are available for men and women. And a lot of it is sort of the interaction that happens in the clinic. And it's often a sort of a multidisciplinary approach, as you heard about the bladder. But there are different pills. Many of you have heard of Viagra, for example, which might or might not be appropriate. There are sort of vacuum devices. There's sort of injections that can help with achieving an erection. There are sort of penile rings, scrotal rings, which help to maintain an erection. And of course, then there's sort of individual and couple therapy, psychotherapy. So there are different sort of facets to the assessment and to the management of sexual problems in someone with dementia. And it's quite important to recognize what's contributing to the sexual problems, and accordingly sort of tailor-made the treatment approach.
Okay, there's no pink Viagra, unfortunately, out there yet, but certainly what we do look is lubrication, because again, a lot of people might be menopausal age, and perhaps we have problems with lubrication, which might make it painful for intercourse, and again, that can people can get agitated that way as well. There's lots of things that we need to advise on, and we talk about vibrators and things like that, and I run a sexual dysfunction clinic for ladies because it tends to be kind of male-orientated topic sometimes, so certainly it's something that we address through that. Okay, that was a bit quick. Sorry, it was very quick, and I do apologise, but I can talk about sex for a long time. So.
Thank you.
Thank you.
So much. Thank you. That's an extremely good overview. So much there. So much for everyone. Do you mind if we go 5 minutes into lunch just to take a few questions? Excellent. So I'm going to give you back the microphone. I have a question while people are thinking. So what I wanted to ask actually was going back to the urinary side. In Lewy body disease and in Parkinson's disease, one of the aspects of thinking and memory that can often be an issue is about spatial orientation. So finding a way around in space. So finding a way to the toilet, and that can be a particular problem, especially for men. Just the practicalities of going to the toilet can make the sort of urge incontinence worse. So I wondered if you had any tips about how to improve that from a kind of thinking that visuospatial problems might be contributing.
And indeed it is a problem. So I suppose the sort of advice would be sort of around sort of signage and lighting, for example, keeping the toilet on, for example. And I suppose if there is a way of sort of flashcards so that an individual who has cognitive